Bismillahirrahmanirrahim. Today we will talk about the left side obstructive lesions. This is the third lecture. We'll talk about aortic stenosis, subvalvular aortic stenosis, supravalvular aortic stenosis, HOCM, hypertrophic obstructive cardiomyopathy, coarctation, interrupted hypoplastic aortic arch, Schoen's complex, mitral stenosis, and core triatrium. This lecture will be divided into 2 or 3 parts. Aortic stenosis, it may be associated with Hunter's, Hurler's, and Turner's syndromes, maybe bicuspid or monocuspid, usually associated with other anomalies. Preoperative assessment, we ask about the age and the weight, history of low cardiac output, congestive heart failure, failure to thrive, signs of LV ischemia. Due to the LV hypertrophy, there may be subendocardial ischemia, which later develops to fibrosis that cause impaired function. These patients start with high demand, LV with high demand. The balance between demand and supply is towards demand. So, due to the high afterload, there is strain on the heart, on the left ventricle, which may lead to ischemia, and then fibrosis, and this fibrosis may impair the LV function, and eventually cardiomyopathy may develop. Endocardial fibroelastosis, due to the fibrosis, the ECG shows LV left axis deviation, LV hypertrophy, LV strain, cardiomegaly in chest X-ray. Critical aortic stenosis with duct-dependent systemic circulation. This is a neonatal emergency which needs urgent intervention if the neonate is shocked. Bleeding is expected, so ensure adequate blood products and start tranexamic acid infusion from the start. This bleeding is caused by many reasons. There are suture lines that may be inaccessible during hemostasis. Sutures at the back of the aorta may be inaccessible to take extra sutures. Just compression with packs may stop the blood. So bleeding at the back of the heart or the back of the aorta is a problem in these cases. Also, the long bypass time, and the fact that if there is bleeding at the suture lines, it is bleeding under high pressure, under aortic pressure. It is an arterial blood. It's with high pressure, so bleeding may be perfuse. The intervention is either balloon valvuloplasty for neonates in the cath lab, but management is mostly surgical, either aortic valve repair, aortic valve replacement, Ross procedure, reconstruction of the aortic cusps, the Ozaki procedure, transcatheter aortic valve replacement, the TAVR or TAVI. In critical aortic stenosis, urgent intervention is needed. Balloon valvuloplasty, PDE stenting if the patient is PDE dependent, or the lower body is PDE dependent, or surgery. In balloon valvuloplasty, approach is retrograde via the femoral, carotid, or umbilical artery. So the catheter or the balloon moves retrograde to the aortic valve, and then it is inflated, or antegrade via the femoral vein or the umbilical vein through the PFO. During balloon inflation, the heart may be stopped for a few seconds by adenosine, rapid overdrive pacing, or esmolol. So effectively the heart becomes cardioplegic for a very short time. That's why we need a very short acting drug like adenosine or esmolol, or overdrive pacing with a rate of 180 to effectively stop the heart. This is the Ross procedure. In the Ross procedure, we replace the native pulmonary artery with the aorta. So the point is, in children and in young adults, usually aortic valve repair is difficult because the aorta has a complex anatomy and it's a high pressure system. So repairing the aortic valve may be challenging and may not be successful, and aortic repair regurg may occur. So unless the pathology is simple and clear, and it involves only one step for repair, usually repair is not successful. Replacement is also troublesome because in young adults and in children, replacing the aorta with a tissue valve render the patient liable for a redo operation in a short period, like 10 years or something, when the tissue valve degenerates. So you condemn this patient to redo operations every almost 10 years for a lifetime. So a young adult or a child may go through maybe 4 or 5 redo operations, which is very dangerous. So a tissue valve replacement is not a good option for young adults and children. So a mechanical valve is the best option, but with mechanical valve the patient would need to take anticoagulant, mainly warfarin, for life. So for a child to take warfarin for life is also demanding and difficult, and is liable for complications, either thrombosis stuck or hemorrhage for overdosing. And mainly in women in childbearing period, this would be challenging if she gets pregnant. So they found that the best option for these patients is Ross. In Ross operation, we take the native healthy pulmonary valve and the living pulmonary valve of the patient, and we put it in place of the diseased aorta. So the patient gets a living tissue, a living valve in as a replacement for the aorta, and this living valve contains living tissue, contains fibroblasts. It heals, it grows with time, it heals the wear and tear of the high blood pressure and the aging process. It heals, it grows, so it lives with the patient for life without degeneration and without needing further replacements. Then in place of the pulmonary valve we put a tissue valve like a homograft or a freestyle. A tissue valve, a dead tissue valve, like a homograft or a freestyle, eventually degenerates, but more slowly than the aorta, because the pulmonary system is a low pressure system. So wear and tear is less, so degeneration takes a longer time. Also, patients tolerate pulmonary stenosis more than aortic stenosis. So a patient may live with a severe pulmonary stenosis for a longer time than aortic stenosis. With a severe pulmonary regurg more than an aortic regurg. So it's more tolerable. And then if pulmonary regurg occurs, a transvenous pulmonary valve replacement may be done. So this is a very good option. However, it involves more bypass time, it involves more suture lines, more bleeding. As I said before, if bleeding comes from the backward sutures, it is difficult to reach or to take further sutures, so packing is the only option. So the procedure itself is longer and maybe more difficult with more bleeding, but eventually with success the patient lives better with the Ross operation. Intraoperatively, we keep hemodynamic goals, maintain good preload. We avoid hypovolemia because the stiff left ventricle needs volume. Inotropic support is not necessary. These patients have fixed cardiac output, so we with a fixed cardiac output, the cardiac output is dependent on the systemic vascular resistance. So the cardiac output equals the blood pressure equals cardiac output times systemic vascular resistance. So with a fixed cardiac output, we need to maintain the systemic vascular resistance, and we need to avoid decreasing cardiac output further by either tachycardia, in which the patient is unable does not have enough time to fill the heart. Also with hypovolemia, the cardiac output falls, so we avoid hypovolemia. Make effort to increase myocardial supply and decrease demand. So avoid tachycardia, which increases the demand. Avoid profound bradycardia because it decreases the cardiac output and decreases the diastolic pressure that perfuses the coronaries, because the coronary blood supply is during the diastolic time. So with profound bradycardia, the last part of the diastolic time, the blood falls greatly. So with profound bradycardia, the myocardium becomes ischemic at the end of every heartbeat, at the end of every diastolic time. So we avoid this. We maintain normocardia without tachycardia or profound bradycardia. Maybe some bradycardia is acceptable, but profound bradycardia is not. Avoid anemia. Avoid hypoglycemia, hypoxia. Maintain high systemic vascular resistance to maintain blood pressure in presence of fixed cardiac output. Be very careful with inhalation induction if needed, and better avoid inhalation not to lower systemic vascular resistance. Ketamine IV or IM can be used. With TE, we check the aortic the gradient across the aortic valve by continuous wave Doppler. We measure the mean and peak gradients. The mean gradient accurately predicts the real transvalvular gradient, but overestimates the peak gradient. To explain this more, by looking at this graph, this is the pressure wave of the ventricle. Rises to the systolic pressure and then falls to almost zero. And this is the aortic waveform. It rises with the systole, and then because of the closure of the aortic valve, it doesn't drop to zero. In aortic stenosis, there is difference between the left ventricular peak systolic pressure and the aortic peak systolic pressure due to the stenosis. But in a normal patient, the aortic pressure is almost identical to the left ventricular pressure. So this is the difference that we want to measure. However, the peak aortic gradient is a little later than the peak left ventricular gradient, because blood travels from the left ventricle to the aorta. So blood takes time to travel from the left ventricle to the aorta. That's why there is this little difference in time between the peak LV and the peak aortic pressures. When we measure these peaks in the cath lab, we put the catheter in the aorta and then measure the peak, and then we pull the catheter in the left ventricle, or the other way around. We measure the pressure, the peak pressure in the left ventricle, and then we pull the catheter to the aorta and measure the aortic peak pressure, and then we subtract these from each other, and we get the gradient across. This is done over many heartbeats, or one measurement is taken, then we pull the catheter and the other measurement is taken. But with echo, the gradient measured is instantaneous. So we measure the gradient across the aortic valve instantaneously. So we start with this is the shaded area. We start with this gradient, and then the gradient rises to the peak. This is the peak gradient, the maximum difference between the two waves, and then the wave decreases until it stops. So the echo measures this difference and not this difference. So the echo overestimates the difference between the peaks. However, when we measure the peak gradient across the left when we measure the mean gradient across the left ventricle and the mean gradient across the aorta, and we subtract these from each other, we get similar results from either the cath lab or the echo. So this difference between the measurement of the peak in the cath lab and the echo is much less with the mean pressure gradient measurement. So it is better to measure the mean gradient and to depend on the mean gradient in aortic stenosis rather than the peak gradient. Aortic valve may be thick, dysplastic.
اقتربت صلاة العشاء.
Measure the left ventricular outflow tract diameter, the annulus, the sinusovalsalva diameter, the sinutubular junction, and the ascending aorta diameters. Try to decide whether the valve is repairable or not, because this may be a very good option. If it is repairable and successfully repairable, we avoid all the hassle of the replacement with tissue or mechanical or the Ross operation. So a repair is the best option if possible. Left ventricular hypertrophy and dilatation and left ventricular function. Poor LV function underestimates the gradient, because to generate a gradient we need a good LV function. So if the LV function is poor, the gradient is underestimated. So in these cases we measure the aortic valve area by planimetry or by the continuity equation. These measurements are not affected by the LV function. We check other anomalies. We do a full study. We check other anomalies. The risk for mortality increases with if the LV long axis is shorter than the heart long axis. So the LV is short and hypertrophied. If the indexed aortic root diameter is less than 3.5 centimeter per meter squared, and if the indexed mitral valve area is less than 5.75 centimeters squared per meter squared body surface area, we measure the pulmonary valve diameter and assess the presence of regurg or stenosis in all cases. Even if repair is planned, the decision may change to Ross intraoperatively. So in any aortic stenosis case, we should be prepared for a Ross operation. These are the measurements. The mean, if you notice, usually, mostly the mean pressure gradient is measured, not the peak. As we said before, the mean is better. So the mean is, if the mean is more than 40, this is considered severe. In other guidelines, more than 50 is considered severe. Peak transvalvular velocity is more than 4 meters squared. Index aortic valve area is less than 0.6. Intraoperatively or practically, we measure the aortic valve area if less than 1 centimeter squared is considered severe. But more accurately, this measurement should be indexed. So an indexed aortic valve area less than 0.6 is severe. Velocity ratio is a dimensionless measurement. We measure the difference between the velocity of blood at the aortic valve and in the LVOT, at the LVOT. So the blood accelerates from the LVOT to the aortic valve. If the acceleration is more than 4 times, or if the LVOT area, if the LVOT velocity is less than quarter the aortic velocity, this signifies severe aortic stenosis, without the need to measure the LVOT diameter or doing a continuity equation. This eliminates the error caused by measuring the LVOT diameter, because the LVOT, we may measure it wrong, and the LVOT may not be a perfect circle. So this dimensionless index, or this index that depends only on measuring the blood velocity at the aorta with the continuous wave Doppler, and at the LVOT with a pulse wave Doppler, decreases the risk of errors, decreases errors, and renders the assessment more accurate, but without being able to measure an aortic valve area. So, for example, if the peak, if the velocity is 4 meters squared at the aortic valve and 1 meter squared at the LVOT, this signifies severe aortic stenosis. Post bypass, we check the LVOT gradient. Usually we don't need inotropes unless there is preoperative cardiomyopathy, congestive heart failure, or LV dilatation, or there is segmental wall motion abnormalities caused by the cardiopulmonary bypass, like if the heart is stunned, or there is infarction, or coronary stenosis, or whatever. So in these cases we put inotropes, but usually we don't. Usually the left ventricle is hypertrophied. We do not need inotropes. Good filling to support the hypertrophied LV. Bleeding is expected, so avoid hypertension, because hypertension increases the pressure at the suture lines and the bleeding, so we avoid hypertension, and also we avoid hypotension, not to cause ischemia to the hypertrophied left ventricle. The TE post, we measure the LVOT gradient, the presence of aortic regurg, and the LV function. We may expect, after removing the afterload, the high afterload at the aortic valve, we may expect a HOCM and SAM of AML, systolic anterior motion of anterior mitral leaflet. So we should check the gradient across the LVOT after bypass. Thank you.